Hello, today is my 9th and second last class on immunization. Today I will discuss MR vaccine, pneumococcal conjugate vaccine and human papilloma viral vaccine. Starting with MR vaccine. MR vaccine, this is introduced to prevent measles, rubella infection and their complications. As all of you know, measles and rubella has very bad life-threatening complications, so it's very necessary to control these diseases. The measles component was introduced in Nepali schedule in 1982 and the rubella component was added in 2013. June 15th, 2013, the measles vaccine was replaced by MR vaccine in Nepal immunization schedule. It is a freeze-dried vaccine, so it needs reconstitution with the diluent, and diluent is supplied along with the vaccine. Here, the measles component is derived from Edmonton-Zagreb strain of attenuated live measles virus, which is grown in chick embryo fibroblast cells. And rubella is derived from Whistler RA27-3 strain of the virus, which is grown in human diploid fibroblast cell culture. Let's see the composition of MR vaccine per dose. Per dose is 0.5 ml. So 0.5 ml of the vaccine contains measles, that is live attenuated. It contains equal to or more than 1000 CCID. CCID is cell culture infectious dose 50% of measles virus, that is Edmonton-Zagreb strain. And rubella virus, that is also live attenuated, it contains equal to or more than 1000 CCID 50 of rubella virus of strain RA27-3. The other composition of this viral vaccine is 5% of sorbitol or sucrose, 2.5% of gelatin or amino acid, 0.5 ml of sterile water, that is diluent, 25 microgram of neomycin, human albumin trace, there is a buffer salt which is sodium phosphate, and there is no preservative. So all these components, it helps to keep the vaccine more stable and effective. In detail regarding the vaccine, it is the type of vaccine is live attenuated vaccine. Schedule: first dose at 9 months, second dose 15 months of age, dose 0.5 ml, injection site anterolateral aspect of the upper thigh, route subcutaneous, storage it should be stored at +2 to +8 degrees Celsius. It is sensitive to heat and light. So the vial containing this vaccine is brown colored. And discarded, it should be discarded 6 hours after the reconstitution. It should not be kept back into the refrigerator, but it should be discarded after use, 6 hours after reconstitution. The side effects: there are some local reactions like mild pain and tenderness. Patient may have mild fever, malaise, 7 to 12 days of vaccination, that occurs in 5 to 15% of the cases, and 2% children may develop measles-like rash, that is 7 to 10 days after the vaccination, and 1 in million doses may get encephalitis-like symptoms. And then very rarely there might be anaphylaxis reaction or allergic reaction, which is extremely rare. If it occurs within 24 hours. Other side effects can be thrombocytopenia, that occurs in 1 in 30,000 doses, and then some can develop aseptic meningitis, lymphadenopathy can occur, toxic shock syndrome, 5% develop temporary joint pain or acute arthritis. And contraindication of measles MR vaccine is during the high-grade febrile state or acute infectious disease, you defer the vaccination. Severely immunocompromised children in malignancy like leukemia, lymphoma, you should not give. Advanced HIV or untreated TB, you should not give. Severe malnutrition, you should not. All these conditions, you defer the vaccination. And people who are getting immunosuppressive therapy like high-dose steroid, immunosuppressive drugs or radiation therapy, in these conditions also you do not give the MR vaccine. You can give it later after the treatment is completed. It is contraindicated during pregnancy. If there is a severe reaction to previous dose, then this is a strict contraindication, absolute contraindication. And infants less than 6 months, you do not give the MR vaccine. And chronic illnesses of any systems, you not give the live vaccines. And with administration of the gamma globulin, again vaccination, if you give, it is not effective because it is neutralized by the antibodies. And if anyone is allergic to neomycin, then also this is contraindicated. In Nepal immunization schedule, second dose of MR was introduced in 2015, that is 2 years after starting the first dose. This was planned because, number one, to protect the children who did not respond to first dose, because with first dose it was noticed that approximately 85 to 95% developed immunity. The rest did not develop immunity. So second dose would be a boostering dose. Number two, to increase the overall immunity in the community, because with the second dose it was seen that the immunity increased to 97 to 99%. So if the protection is so good, it helps to achieve herd immunity. So if the herd immunity is achieved, then it prevents outbreak. So the second dose was planned. Number 3 point, global effort to control and eliminate measles and rubella. So for this purpose, second dose, with the second dose, since the immunity was much better, so second dose was planned. It would help control and even eliminate the disease. Okay, in Nepal we give MR vaccine. Why not MMR? Because many countries they give MMR vaccine, but in Nepal we give MR vaccine. So that we have different reasons why this MMR was not introduced in Nepal. Number one reason, mumps is not a major public health problem in Nepal, because complication of measles is much severe, and then rubella complication is also very bad, as congenital rubella syndrome is a fetopathy which gives a handicapped child to the parents. And the mumps complication is not so commonly occurring in children, so till 9 years of age mumps complication is very less, minimum, and then that is the commonest age when below 9 years is the commonest age when mumps is occurring. So this is not a major health problem in Nepal. Number two, government priority to eliminate measles and rubella. So target of government was to eliminate, to control measles and rubella and not mumps. MR vaccine is cheaper also, so cost effective. Since this is a national program, the vaccines are given free of cost, so this would be easier for developing country like Nepal. And then WHO regional strategy. The WHO strategy is focusing on eliminating or controlling measles and rubella and not measles. So Nepal was just following the WHO strategy also. So for these few reasons, MMR was not introduced in Nepal. So instead of MMR, we practice MR. Okay, now I'll give you some tips on monovalent measles vaccine, because measles vaccine was practiced in Nepal immunization schedule for a long time, starting from 1982 till 2013, before rubella MR vaccine replaced the measles vaccine. So in few slides I'll just tell you in brief regarding the monovalent measles vaccine. This is a live attenuated vaccine developed by Enders in 1960. The virus strain was isolated from a child by name Edmonston. So therefore the strain was also named Edmonston A. After attenuation, it was called Edmonston B. So this vaccine was developed with further several attenuation of the Edmonston B, and the strain which is used as measles vaccine is Swartz, Moraten, Edmonston Jackreb. So this Edmonston Jackreb was used in Nepal starting from 1982. So when replaced with MR, the same strain is continuing. It is a freeze-dried single dose or multi-dose vial. It comes in a multi-dose vial also. Diluent is distilled water, same as MR vaccine, and the potency of this vaccine is 1 to 2 years. It is susceptible to contamination because it does not contain preservative. Even MR does not contain preservative, so they are susceptible to contamination. After reconstitution, the potency drops very rapidly, and there is a risk of staphylococcal toxic shock syndrome, which is one of the very bad complications of measles vaccine, if it is used after 1 to 2 days. That is why the reconstituted vaccine should be discarded after 6 hours. So in brief, it is live attenuated Edmonton-Jacob strain grown in purified chick embryo cells. Schedule was just 1 dose was given at 9 months of age. Dose was 0.5 ml. Injection site anterolateral aspect of the upper thigh, root subcutaneous. Storage same as MR vaccine, frozen or refrigerated at +2 to +8 degrees Celsius. It is sensitive to heat and light, same as MR vaccine, and the reconstituted vaccine should be discarded within 4 to 6 hours. Do not keep it back to the freeze. The antibody titer of measles vaccine, it wanes away over years, but the measles specific cellular immunity which is produced, it persists and for a long time and provides immunity for lifelong. The immunogenicity is lower in immunocompromised, including the HIV. So those children, we do not give measles vaccine. HIV infected infants, they have superior seroconversion rate at 6 months as compared to 9 months, because in them progressively immune system gradually deteriorates as the age increases. So at earlier age, the seroconversion is much better for HIV children. Usually, it is not given in less than 9 month age children because the maternal antibody, it interferes with the immune response to the vaccine. So it neutralizes the vaccine effect. So less than 9 months, if you give also, it is of no use. Measles endemic areas, zones, they give vaccine at 9 months of age. Even Nepal was practicing this because we were also measles endemic zone. In countries where measles is very low, it is given at 12 to 15 months of age. And during measles outbreak, you may have to give even at 6 months. But if you give at 6 months, or if this vaccine is given at age less than 9 month age, then you need to give a repeat dose at interval of at least 3 months. Preferable age is after 12 to 15 months of age. When transmission of measles is very high, then in that area, that time, you give 2 doses, one at 6 months, another at 9 months of age. So this is some points you need to remember. The seroconversion rate, there are some challenges for measles vaccine, especially for the developing countries. The seroconversion rate for the measles was noticed that with increasing age, the seroconversion is better. 60% at 6 months, 80 to 85% at 9 months, and more than 95% at 12 to 15 months. So it is obviously better if you give vaccine at 12 to 15 months, since the seroconversion or the vaccine immunogenicity efficacy is much better when it was given at 12 to 15 months. So it is best if you can give beyond 12 months. But the problem is in the developing countries, the significant proportion of children, they get measles at age less than 12 months. So to protect them, those places we have to give vaccine at earlier time. So we are giving at 9 months. Okay, next vaccine is pneumococcal vaccine. So first let's know what is pneumococcal disease. Pneumococcal disease is disease which is produced by Streptococcus pneumoniae. So those diseases are also life-threatening. Examples are bacterial meningitis, pneumonia, otitis media, bacteremia or septicemia, and then sinus infections. So pneumococcal vaccine is produced against Streptococcus pneumoniae. There are two main types of vaccines. Number one, pneumococcal conjugate vaccine. So this is practiced in the schedule. Another is pneumococcal, number two is pneumococcal polysaccharide vaccine known as PPSV23 or PPV23. And then pneumococcal conjugate vaccine is shortly known as PCV. Let's start with the description of the PCV. So this is a conjugated vaccine which is conjugated with a protein. After conjugation with protein, it gives a strong immune response, especially to the younger children, infants, or less than 2-year-old children. And there are different types of PCV vaccines. PCV7, this is an older vaccine. This covers only 7 strains of the pneumococcus. PCV10, it protects against 10 serotypes. And this is the one we are practicing in Nepal immunization schedule. And another is PCV13, which protects against 13 serotypes, famously known by the name Prevenar. And then PCV15 and PCV20, these are the newer vaccines which are available. So these are the different types of pneumococcal conjugate vaccine. Number 2 vaccine is pneumococcal polysaccharide vaccine known as PPV23. So famous, the brand which is used is Pneumovax. And here it covers 23 serotypes. So all these are the serotypes which is covered by the pneumococcal polysaccharide vaccine. But the immunity induced is they stimulate B cells which produces IgM. So IgM has a shorter duration of life, so this vaccine must be repeated every 5 to 6 years. So revaccination is necessary every 5 to 6 years. And this vaccine is not effective for children less than 2 years old. So in the vaccination schedule, this cannot be used because these children, they have less developed immune system, so does not have a good response. It is also ineffective for older adults because they have weaker immune systems. PPV23 vaccine dose is 0.5 ml route intramuscular, schedule single dose, and if you repeat, you will repeat after few years, every 5 years. Many centers they practice every 5 years. Age you can give only to children 2 or more than 2-year-old, and the indication of this vaccine is this is given to the high risk patients. So who are the high risk patients? Let's see. The high risk populations for that vaccine is sickle cell disease, where there is a functional asplenia, and children who undergo splenectomy, this is important, immunocompromised state like HIV, malignancy, organ transplantation, immunosuppressive therapy, chronic kidney disease or nephrotic syndrome children, CSF leaks or cochlear implant, chronic heart, lung, liver diseases, diabetes mellitus. So all these are high risk populations who should receive this vaccine. So when you give this vaccine initially in the places where you practice PCV and in the schedule vaccine, after giving schedule vaccine of this, then only you give PPV23 after age 2 or more than 2 year age. And in places where you do not practice PCV in the schedule, then you complete the PCV vaccine first, then only you give PPV23, that will be after age 2 years or more than 2 years. Okay, pneumococcal PCV10, that is we are practicing in the Nepal National Immunization Program, and this vaccine was introduced in the schedule in year 2014. WHO, World Health Organization, it recommends 3 primary doses with a 3P plus 0 schedule or 2 primary doses plus a booster, that is 2P plus 1. So in Nepal we practice 2P plus 1. So here it is given at 6 weeks age, 14 weeks age, and then booster at 9 months. And this vaccine is co-administered with the pentavalent and OPV at 6 and 14 weeks, and with Measles-Rubella vaccine at 9 months. So if you administer multiple vaccine at a time, then you are supposed to give vaccines at different sites. So if pentavalent vaccine is given in the left thigh, you give the PCV vaccine on the right thigh. So that way you need to select different sites. Okay, disease covered by PCV10 is the invasive disease, pneumonia and bacterial meningitis, and the non-invasive disease, otitis media, sinusitis, bronchitis. So all the disease this PCV10 covers. Serotypes 1, 4, 5, 6b, 7f, 9v, 14, 18c, 19f and 23f. So these are the 10 serotypes. Route is intramuscular, and then the amount is 0.5 ml given at right anterolateral thigh. Storage +2 to +8 degrees Celsius, and do not freeze this after reconstitution. At the end of the vaccine session or after 6 hours, you are supposed to discard this. There are more than 90 serotypes of the pneumococcal bacteria, and PCV10 protects against 10 serotypes, and that covers the most life-threatening infections. Main drawback of this conjugated vaccine is it is providing protection against only some subset, like PCV10 covers only 10 serotype where there is a 90 serotype of the pneumococcal bacteria. This is the only disadvantage, but PCV10 is covering good number of serotypes. The bacteria which is causing severe disease, it is covering that. So it is effective. The adverse reactions, there are some mild adverse reactions, local reactions like redness, pain and swelling. There can be mild fever, fatigue, headache, chills, and then severe reaction. Till now no proven severe reaction till date. So this is a very effective vaccine. Okay, third vaccine for today is Human Papilloma Virus Vaccine, HPV vaccine. Human Papilloma virus, it causes cervical cancer in the females, and this is the second most common cancer occurring in the ladies worldwide. This virus also causes genital warts. There is a huge burden of the disease, with the 13% of the females having the cervical cancer per year, and more than 85% of cervical cancer death is occurring in the developing countries. So this vaccine is very, very important to decrease the burden of this disease. With the natural infection with the human papilloma virus, it induces only weak immune response. With the vaccination, it induces higher antibodies in the blood and also at the site of infection. So it is very, very protective because it is producing good number of antibodies even at the site of infection. So vaccine induces higher antibody levels in the blood, which means higher antibody level at the site of infection. So it has a very good protection. So these antibodies are neutralizing this virus and prevent the entry into the cell, so doesn't let the infection spread to the normal cells. So at the site of entry only, it is killing the virus. FDA, that is Food and Drug Administration, it has approved 3 vaccines globally for use against HPV infection. So number 1 is Gardasil, number 2 Gardasil 9, 3 is Cervarix. So Gardasil, it covers this is a quadrivalent vaccine covering 4 serotypes 6, 11, 16, 18. Gardasil 9, it is a nonavalent, that is a 9-valent, protecting against 9 serotypes. And Cervarix, it is a bivalent vaccine which is covering 2 serotypes 16 and 18, and this one is being used in Nepal immunization schedule. So in general, dose for these vaccines is 0.5 ml intramuscular deltoid upper arm. And then the schedule, primary vaccination schedule is 3 doses. The target population is girls 9 to 25 years old. So the bivalent vaccine is given at 0, 1 and 6 months. And the quadrivalent vaccine is given at 0, 2 and 6 months. And this has adverse effect like local pain and fever. Contraindication is only if there is a anaphylaxis after previous dose. With the previous dose, if there was anaphylaxis, then it is contraindicated. Otherwise, you can give this vaccine. Now the human papilloma virus vaccine, which is we are practicing in Nepal immunization schedule. This was added in the schedule in year 2025, that is last year. And the vaccine used is the bivalent one, that is Cervarix, which covers type 16 and 18, serotype 16 and 18, which is responsible for most cervical cancers. The target population are girls aged 10 years, that is children of grade 6. And dose 0.5 ml single dose. Route is intramuscular, site is deltoid upper arm. The role of vaccine is it induces high antibody level at the basal epithelium of the cervix, at the local site. So induce a long lasting and very effective protection against this virus. And then actual dose is 3 doses recommended, but why single dose in Nepal? So here Nepal is following recommendation of WHO, because WHO has concluded that 1 dose of human papilloma virus vaccine provides very strong protection against the human papilloma virus infection, especially at age 9 to 14 years for the girls. So Nepal, the target population is 10 years. So the age group is falling within this range. So only 1 dose is sufficient. But in general, the target population is till 25 years. So for them, 3 doses are required. So this is the reason in Nepal we are giving only 1 dose, single dose. Okay, even for males 9 to 26 years, they can use this vaccine to reduce their likelihood of acquiring a genital wart. Protection till date, duration of protection against this targeted human papilloma virus types are with the Gardasil, at least 8 years protection is there. Cervarix, at least 9 years protection is there. And then for Gardasil 9, till now protection duration is not yet known. Okay, thank you. Hope this class was useful for you. So today we complete the routine immunization schedule. Next class I'll discuss some optional vaccines and then some vaccines which is given in some special situations. That also you have to know, especially for the MD students. So I'll discuss those in my next class. Thank you.